Good afternoon, and welcome to today's program titled Emergency Preparedness Concepts and Requirement of Participation for LTC Facilities. I'm Megan Combs, moderator for the Institute for the Advancement of Senior Care. Today's program is sponsored by Omnicare. Thank you to our sponsor and to our audience for joining us today. Before we get started, we have a few housekeeping details to go over. Please use the Q&A area below the slides to submit a question at any time. You do not have to wait until the end of the program to submit a question for our speakers. To download a copy of the presentation, please click the link in the Resources tab to the right of your slides. Finally, if you're having technical issues, please click the Test Your Connection button below the video window to chat with support. A special note about CE credit. To get your CE, you must watch the program all the way through the Q&A section at the end of the program. Please do not leave the console. The site will automatically direct you to your certificate. For those of you watching in a group, please download the group submission guide in the Resources tab and follow the instructions provided. Please note that CE credit is not available for the archived webinar. It is only available for today's live event. Finally, join our conversation on Twitter by tweeting with the hashtag IASCLiveWebinar. At this time, it is my pleasure to introduce today's speaker, Stan Szpytek. He is the president of consulting firm Fire and Life Safety in Mesa, Arizona, and is the Life Safety Disaster Planning Consultant for the Arizona Healthcare Association and California Association of Health Facilities. Stan is a former deputy fire chief and fire marshal with more than 35 years of experience in life safety compliance and emergency preparedness. Stan is joined by Nancy Lobson, consultant pharmacist and chief quality officer at Omnicare. Thank you, Stan and Nancy, for taking the time to speak with us today. And with that, Stan, the audience is yours.
Well, thank you, Megan, and it's great to be here, coming to you live from sunny Mesa, Arizona, where this weekend it's going to be 103 degrees, and I've got a tea time with my brother who's coming in to visit. It's been beautiful all week long, and it's going to get hot. And thanks for that great introduction. You know, I like the folks on the webinar today to know who's speaking with them, and I think you get it. I have a background as a first responder. I had a great career in the fire service in the Chicago area, starting at a young age while I was still a cadet in high school, and getting lucky enough in 1983 to get hired as a full-time firefighter paramedic. And like a lot of us on the call can relate to, 20 years of a career kind of came and went. I kind of grew up through the ranks, became an officer, a lieutenant, a captain. I was the community's fire marshal. On my watch in my community, I had 3 long-term care facilities, skilled nursing facilities built. I had an assisted living community. I had a large CCRC campus along with a huge community hospital. And along the way, those properties needed assistance with making sure that they had evacuation systems in place. And little did I know that my time on the fire department was my training to ultimately become a consultant and work with long-term care providers around the nation. So at the ripe old age of 41, I retired from the fire department. I did what all good Chicago area firefighters do. I moved to Mesa, Arizona. And actually, you know, I didn't retire at all. I kind of refocused my energies, my passion, my training, my skills to help long-term care providers like those on the line today, whether you're a skilled nursing facility or not. If you're one of the 17 provider types that are affected by the new CMS rule of participation, or if you're an assisted living provider or another level of long-term care, you know, everything that we're going to talk about today is going to be great best practice. And for those of you that are in the requirement world, we're going to try to outline in a pretty clear way that you've got a lot of new requirements of participation that you need to deal with. And I think it's my job not so much to educate you, because you've seen the documents, you've gone to the sessions at your state associations, you've been reading the articles and publications that are out there. And you know that there's a lot to do, but I think my role today in the time that we have is designed more to be a motivator and to inspire you, that you've got to understand that it is not just compliance for compliance sake, that there's a real effect if we're not prepared for every kind of emergency. You know, in addition to working with the state healthcare associations, I oftentimes am invited to other state associations to present, and I've been doing that coast to coast over the last couple of years since these new requirements of participation have rolled out. But I also work on the insurance side of the dynamic. I work with loss control folks at companies like Gallagher Bassett, and you know, I think I get it. I understand your business and understand all of the things that you've got to worry about. And as I just said a second ago, it isn't just compliance for compliance sake. You've got to understand that there is an emergency management dynamic that's out there, and it's a continuum. Just like people you serve come in through your system on that continuum of senior care, you know, it starts with preparedness, and then we've got to concern ourselves with the with the mitigation of the incidents that occur. Once the incident happens, we've got to make sure that we're ready to respond, recover, and maintain a continuity of care and a continuity of services that will provide a safe environment of care for all stakeholders. And when I say all stakeholders, I'm not just talking about the residents, the patients, the consumers, the guests, the neighbors, and all the different names that people you serve go by. But I'm talking about your staff, I'm talking about your visitors, I'm talking about everyone that needs to be addressed in that emergency management continuum so that when disaster strikes, you respond, you recover, and then you mitigate again and you prepare, and then another disaster strikes, and that continuum continues on and on. You know, a few years ago, one of my strategies for presenting was to try to make a case to the audience that bad things happen to good people. And I think with the way things have changed in society, everything from high-profile events like the tragic shooting in Florida not that long ago to wildfires that are happening here in Arizona and in other states, to incidents as recently as yesterday in Georgia where that C-130 plane on its way here to Arizona unexpectedly crashed on a highway, could have crashed into a neighborhood. We've got to understand that anything, anytime, anywhere can happen. And long-term care is not immune from the bad things that happen out there. You know, as you may imagine, and if you haven't figured it out already, but I know we're early on in the discussion, you'll get it by the end. I'm a disaster geek, and I get texts, I get notifications, I get tweets, I get Facebook posts that show all the bad things that are happening out there in the community. And it wasn't all that long ago that an issue of domestic violence spun out of control, found its way into a long-term care facility. 2 employees were killed. A responding police officer, the police chief, was killed. And a bad thing happened in a small community. This facility was only a 25-bed facility in rural Ohio. And if it can happen there, you know, it can happen anywhere. Think about what happened in San Bernardino during a holiday party not that long ago. People that deal with developmentally disabled folks in the community were at that regional center when all of a sudden the gunman burst in, the shooting started, emergency responders were on the way, and that community to this day is still recovering from the tragic events of that particular incident. You know, we've got to think about all of the threats and perils that are out in our communities. Those that are out there regionally, like in coastal areas, who've got to start worrying about hurricanes when the season starts. We know that they've got a pretty profound effect on long-term care providers' ability to provide services. And you need to plan. You need to prepare. And, you know, we saw evidence of a tragedy that happened in Hollywood, Florida last year following Hurricane Irma. And we know that we've got to make sure that we're ready for anything. When the power goes out, when our facilities become uninhabitable, when the tornado touches down, we need to make sure that we are ready with plans, with programs. And programs is a key thing that I'll talk about when we get into the Emergency Preparedness ETAG section of the program. That's when we start talking about compliance. You know, every community has some type of peril. You might be surprised to know that even here in the Valley of the Sun, in the desert, according to our risk assessment or our hazard vulnerability assessment, flooding is something that we've got to concern ourselves with. Yes, here in the desert, flood is one of the biggest threats that we have to deal with. And there are other things out there in our community that we don't always acknowledge until something bad happens. You know, just a few years ago at a small nursing facility in West Texas, a fertilizer plant had caught fire. That fire got to the point that the fertilizer material, a lot of bad chemicals, started to burn. When that type of material burns, it explodes. When that detonation occurred in West Texas, it took down buildings. The concussion wave crashed into the nursing home. And according to the director of nursing, who we had come out speak in Arizona a few years ago, and she talked about the challenges of that disaster, she talked with a lot of pride how her team came together, how they followed the plan, how they were ready for disaster, and how they overcame those types of adverse events. But when it comes to hazard vulnerability assessment, you know, we have a tendency of only looking at the obvious threats. I mentioned that I work with insurance companies, and a lot of times I'll get dispatched to a client somewhere in the United States. I'll look at their emergency preparedness program. I'll take into consideration their hazard vulnerability assessment. And more times than not, until these new requirements of participation went into force, I would always see a lot of obvious focus on the disaster management program. It was always very geocentric. For example, if the facility was in the Midwest, like where I come from, the focus was always severe weather and tornado preparedness. If you were in a coastal region like Florida, Alabama, Texas, Mississippi, everything seemed to be very hurricane-centric or focused on tropical depression. In the Northeast and the northern parts of the country, we had to focus on winter storms and ice storms, things like that. In the desert, obviously, excessive heat, and as I mentioned, flooding. When the hard rain comes and that hard ground doesn't absorb that water, we've got a lot of flooding that occurs. And many of those floods have occurred at some of our healthcare facilities here in Arizona. If you're in a seismic region, everything seems to focus on earthquake. You know, I know you're going to feel sorry for me. I've had to go to Hawaii and do some work there as well. But when I work with the folks in Pearl City and in Honolulu and in Maui, you know, I've seen some of the best tsunami preparedness and response plans than I ever seen before. I never thought there were tsunami plans, but there are. And again, if you're in a floodplain near a river, your focus is always going to be on those rising waters. But the reality is we've got to look at what's beyond the fence. CMS, best practices, and just good disaster planning concepts tell us that we can't only focus on the obvious. We shouldn't only focus on the nose in front of our face. If we're in a metropolitan area, we shouldn't just worry about hazmat incidents that occur on the rail or the potential for a terror attack. We've got to look beyond the fence, and we've got to factor in all those threats, all the perils that could impact our facility. Your disaster planning needs to focus beyond your own four walls and your roof. You've got to look out into the community, and you've got to ask yourself, what if that rollover happens in front of my facility? What if that train derailment a quarter mile upwind from my facility and that ominous cloud of dimethyl terrible is making its way low to the ground because the plume of smoke or the gas that's leaking has a greater specific gravity than the air around us, and we've got a potential for an explosion? What happens when that active shooter barges into an elementary school, a shopping mall, an office building? I remember at the Arizona Healthcare Association offices not that long ago, we had to go on a lockdown because there was an active shooter on the loose. He had barged into an attorney's office. This was the attorney that represented his soon-to-be ex-wife. He shot a few people. He terrorized the neighborhood. He led the police on a chase. And everyone in that area, including schools and shopping centers and office buildings, had to go on lockdown. What if you are down the street when that incident happens, where it's going to impact your facility directly, Or people may come to your facility to look for services, to look for aid. You might not think it would happen, but in a true disaster scenario, it can happen. And you got to ask yourself, how prepared are we? How prepared are you personally and individually? You know, the vulnerabilities that any type of healthcare provider has during an emergency, like a fire, a power failure, the rising floodwaters, a tornado touchdown, approaching a hurricane, the active shooter that's on the loose. You've got to ask yourself, how prepared am I personally, and how prepared is our facility? You know, if you follow the president's advice and FEMA's advice and others that have spoke about disaster, when disasters were a hot topic, unfortunately, they've been in the news, but we haven't seen the kind of spike like we saw after 9/11 and other tragic events like Hurricane Katrina. But the prevailing message that we've got to understand is that all disasters are local. And if you take that to the purest form of the definition, you've got to think about how a disaster or a crisis is going to affect you and your family. Does your family have a plan? If you're an administrator or someone in authority at your facility, are you promoting personal, individual, and family preparedness so that in an emergency, your team is going to stay put and do their job during a crisis or a disaster, or when you need them and they're at home and the streets are flooded and the lines are down and there's no power in the entire region? Will they make their best effort to get to your facility because you promoted that they need to be prepared and that you need them in times of crisis? You know, one of the biggest things that you've got to acknowledge, and sometimes it's tough to acknowledge this, but things will happen that are beyond our control. What if that main line derails, people are injured, and your employment base is transit dependent, and they're on the BART, they're on the CTA, they're on another municipal or regional transit line coming in from Long Island or all places from coast to coast, and now all of a sudden people aren't showing up to work because of some type of transportation incident? What happens when your outsourced payroll vendor has a fire in their office building in a metropolitan area and records are lost? You know, here in Arizona, it was interesting. When Hurricane and ultimately Superstorm Sandy made landfall on the eastern seaboard, particularly in New Jersey, one of our local hospitals here had to activate their emergency operations center. And remember, I'm in Phoenix, Arizona. They went into emergency operations because during that incident, their servers for their main computer system and their electronic health records was serviced by a building that was on the shore in New Jersey. And as that tidal surge made its way onshore, it swamped out that building, and in a blink of an eye, all electronic health records at that hospital went dark. And the facility found themselves in the midst of a crisis of an incident that was happening 2,500 miles away. Things are going to happen. They're going to be beyond our control. And if there's one thing I need you to walk away from this call today with, it's this. Get that concept, get that thought out of your vernacular that it can't happen here. If it can happen at a small rural nursing home in Ohio, if it can happen at a nursing home in a metropolitan Florida area where people subsequently died due to a power failure and environmental conditions inside of a healthcare facility, it can happen anywhere. You know, I remember as a firefighter, a fire chief, I never responded to that call, your call at your house when it was on fire, or that car crash that you got into at a major intersection. And you never said to me, boy, I knew today was the day my house was going to catch on fire. Or I was always expecting this crash to occur. Nobody thinks it's going to happen to them until it does. And when it does, you've got to understand on the type of business that you're in. These crises, these disasters, these emergencies, big or small, are going to have significant impact on your services. And your plan and your program needs to acknowledge that. So what are some of the lessons that we've learned? What are some of the lessons for us that we got to take away? First of all, and I'm going to read this slowly, disaster planning and exercises are the key to survival, not your written plan. Now, when I talk about compliance on the later half of this program, you're going to hear a whole lot about policies and procedures, requirements of participation, and all the paperwork that you need to have. But when it comes to a disaster or an emergency, it's going to be your training, it's going to be your instincts, it's going to be your gut, it's going to be your culture that's going to get you through. And how well you've prepared with hands-on activities is really going to be the difference. And in some cases, it could be the difference between life and death. You've got to acknowledge that your communication capabilities that you rely on each and every moment of each and every day, they're probably not going to work. But you might find out that in a crisis, when you get that annoying signal that says all circuits are busy, you may still have texting capabilities. And your plan needs to know that ahead of time, and you've got to have contingencies to communicate. Whether you're a Joint Commission facility, a CMS compliant provider, you know that you need to do a risk assessment of your capacities and your capabilities. And some will come up with varying degrees of how much stuff they're going to need during an emergency. But just to use the Joint Commission model of 96 hours, when you factor in new requirements of participation that state you don't only have to have food, water, and subsistence for your residents, your patients, your consumers, your clients, again, whatever you call them, you've got to accommodate your staff and possibly staff family members that end up coming to the facility during an emergency so you can staff your facility. No matter how much supply you think you have, you've got to understand that an overage is always a good thing. Don't ever think that we've got enough, because you'll find out in a true crisis or a disaster, it's never enough. When it comes to electronic health records, well, I've already given you the example. The hospital here in Phoenix, it was a normal day, and all of a sudden, in a blink of an eye, all EHR went down. You've got to make sure that if you say, and your plan states that you're going to use paper backup if our system goes down, you better train your people how to use paper backup. I was presenting at a conference someplace, and there was a salty, distinguished, seasoned director of nursing that was sitting in the front row. And she raised her hand when I made that statement. She says, you know what? Some of the generations of nursing staff and care staff that we see, they don't know how to chart outside the scope of an electronic health record. So if your plan says we're going to chart with paper and pencil, you better know how to do it and teach your people how to do it. Here's a concept that you might not understand until it happens. In an emergency, the desperate public is going to show up. Sometimes you're the biggest employer in a small community. Other times people will just show up because it says healthcare facility or rehabilitation center out in front of your facility. When the big one hits, and hopefully it never does, to the scale of things that we saw on 9/11, people are going to show up at your healthcare facility looking for assistance, looking for care, or at the very least, looking for some comfort. You've got to understand that it could be hours, if not days, before help arrives. You got to understand that in a single focused event, like a fire in your nursing home, and I can think of a few fires that I responded to in my time on the job. More times than not, the administrator will come up to me afterwards, even when it's a real fire, and there's smoke in her building, and the sprinkler system activated, maybe a head or two went off. They'll finally come up to me and say, Stan, why did you send so much stuff? Well, your type of facility is a target hazard. And in a target hazard, we're going to send everything. But the irony is this, in a true disaster, those same first responders are going to consider the fact that you've got care, you've probably got an emergency generator, you've got training, you've got a plan. You're going to get on the lower spectrum of priority in a disaster, and something that I know you've heard before, you're going to be on your own, and your plan has to acknowledge that. The last thing that I want to say about this is you've got to understand that you and your staff will be profoundly impacted by these bad things that happen to good people and good communities. So where do we start? Well, this should be common knowledge for everybody on the call, especially if you're part of the ROP, but you've got to start with a hazard vulnerability assessment. You've got to determine what potential threats and perils that are out there in the community and how are they going to impact your facility. You've got to understand that an HVA is a kind of scientific process that looks at the probability or the likelihood of occurrence. They'll also factor in the severity or the impact of the event and how it impacts our human resources and our patients, residents, consumers, clients, etc., how it impacts our property, how it impacts our business, and so forth. Then the HVA process is going to factor in our levels of mitigation, which basically is a simple equation of our preparedness and our response contingencies. How are we prepared internally? How are we prepared externally? That's going to determine our levels of risk. So here's how it's created for the risk managers that are on the call right now. Our probability plus impact is going to equal our unmitigated levels of risk. Once you factor in your issues like mitigation and preparedness, including things like fire sprinkler systems, fire drills, a fire plan, that will give you the level of mitigated risk, and that will help you determine which types of perils should you concentrate on the most. Here's some good news. There's a ton of resource out there. And on the screen right now, you're seeing an image of the Kaiser Permanente HVA tool. And again, if you've worked with any of the healthcare associations, if you've done some surfing and you've put in the simple terms hazard vulnerability assessment, all roads lead to this spreadsheet right here. It's a document that helps you measure all the threats and perils that are out there, from man-made events to hazardous material incidents to mass casualty incidents and so forth. And there's even good news. In 2017, Kaiser went ahead and updated the HVA tool, and there's a brand new format where it uses a single page versus the multiple pages that you just saw on the preceding slides. And if you're really worried, how do we try to capture every kind of emergency that can potentially happen out there, you'll be happy to know that the last peril listed that you score is zombie apocalypse. So we've got that base covered too. How likely is it to be? What does this all lead up to, a hazard vulnerability assessment? Well, it all leads to something that CMS is promoting, that best practices has always promoted, and it's the concept of all hazards planning. You know, I think back to my time in the fire department. When it was 1977, I was a kid in high school. The community that I had a cadet program. I was able to join the fire department. The cadets were kind of gophers. They were learning the trade along the way. But this is back in the day when we actually were still able to ride on the back of a fire truck. Those are some pretty hairy experiences, riding on a tailboard of a truck going 50 miles an hour down the street. But think about it. Your firemen, the ones that work for you, those first responders in your family, the firefighter that lives next door, your husband, your wife, your son, your daughter, your friend, your neighbor, they used to just put the wet stuff on the red stuff. Think about your firefighters today. They're the first responders to everything, from gas leaks to hazardous materials incidents to mass casualty incidents to shootings to weapons of mass destruction. Yes, we get those cats in the tree calls every now and then too, but today your local emergency responders and specifically your fire service and EMS agencies take that all hazards approach. And what does that look like? What does all hazards emergency management look like to you? Well, you've got to have a program and a plan that's going to address your residents' specific and unique clinical and support needs. If you're a behavioral facility, you've got to make sure that your plan is going to acknowledge the needs of those residents should they have to be evacuated. Are they going to do well in an auditorium or in a general population type environment? You've got to check out those unique needs and make sure you accommodate plans and programs that will accommodate those needs. You've got to focus on those high-risk threats. When you determine what those threats are through HVA, you're going to focus your training, your drills, your exercise on those threats that are most common. You do have to factor in local emergency planning considerations. Now, that fire department that I worked with over 40 years ago when I started, you know, it was a volunteer fire department that specifically responded to fire calls until they brought in EMS and other elements of emergency response. But I remember the days back in 1977, the first summer that I was on, the siren sounded, there was a call for the volunteers, and it was 2 o'clock in the afternoon when everybody was at work and some people were on vacation. And I was the only guy that showed up for 10 minutes until some other volunteers finally arrived on the scene. Do you have a municipal fire department? Do you have volunteers that serve your agency? You've got to make sure that you're looking at everything from command and control to communications to the resources, the assets, the stuff that you're going to need, the safety and security considerations and staff responsibilities during an emergency, because those large-scale events are going to happen. They're going to devastate our communities. They're going to impact our lives. And the question that we have to ask ourselves is, how do we handle these kinds of circumstances? How did those first responders in New York City and in Pennsylvania and in Washington, D.C. and the surrounding area deal with such large-scale events? You know, we got better. We all got better since the tragedy of 9/11 because, quite frankly, police and fire assets, they didn't always work together. And it wasn't until there was some national mandates that were enforced, including the National Incident Management System and the National Response Framework that were published, that basically said all sectors of our society are going to manage emergency incidents the same way. We're going to use the same language. We're going to use the same systems, whether you're fire, police, EMS, a hospital, a nursing home, a healthcare facility of any type. We're going to use a system, and that system has to be standardized. What NIMS says, the National Incident Management System says, is one of the most important best practices that's been incorporated into NIMS is the Incident Command System, a standard on-scene, all-hazards incident management system already in use by firefighters, hazmat teams, rescuers, and emergency medical technicians. Yes, you're a nursing home. Yes, you need to know incident command. Yes, you're an assisted living facility. You need to know incident command because it is the system that your community is using, that your firefighters are using, that your hospital is using, and you've got to understand that you need to be part of that dynamic. So for the specific audience that we have on today, there's great news, not just good news. There's a derivative or a version of the incident command system that was designed specifically for nursing homes. It's called the Nursing Home Incident Command System, or NICS. There were stakeholders from places like the Florida Healthcare Association, the California Association of Healthcare Facilities, the American Healthcare Association, and others that came together and took the incident command system that was in place for hospitals and adapted it to nursing homes so that it will work in your facility. So what are the benefits of this standardized system? Why is NICS so critical to your plan? Because we need to empower our staff. We need to promote interoperability. We need to be efficient, and efficiency comes through delegation. And we delegate through a system of command and control. And once we've got that system of command and control in place, we've got an all-hazards approach that is going to deal with every kind of emergency. Now, there's more, and a lot more. I could speak to you all day, and I would need all day if I was going to train you on the incident command system. But what I want you to walk away with from today is to know that incident command, or the nursing home incident command, is just a simple program of management by objectives. Coming up with the objectives that you need to establish to manage an emergency, assigning or aligning those objectives to an operational period so that you can effectively manage the emergency. Incident command is all about incident action planning, where the person in charge, known as the incident commander, will set up an operational period, develop the priorities, establish SMART objectives. Those SMART objectives are specific, measurable, attainable, realistic, and they can be timed so that you come up with meaningful strategies for those objectives so that you can identify the resources that you're going to need, so that you can issue the assignments, so that you can monitor your efforts, and of course, you need to document your results. So whether it's the fire service, a nursing home, a hospital, a clinic, a surgical center, everybody's going to follow this command. If you prescribe to incident command system, you're going to follow this simple diagram. Somebody's in charge, and that somebody has a command staff that reports directly to them, a liaison officer, a safety officer, a public information officer. And beneath the command staff are the general positions of operations, planning, logistics, and finance. I hope I'm piquing your interest because I want you to go to your healthcare association, to get online, to learn more about the incident command system, so that you understand that that system is used by all of us in emergency response and healthcare, so that if we've got a major incident that involves a full evacuation, we'll have an incident management organizational chart that's fully expanded, like you see in the center of the screen. Or if we have something that CMS says that you need to accommodate in your emergency operation program as minor, and I don't mean it in any way other than it's not a major disaster, but it's an emergency, as minor as a missing resident, you need to go into that format of command and control so that you can manage the emergency. Here is really good news. On the CAF website, the California Association of Health Facilities, they're kind of like the gatekeeper of a lot of the documents, or all of the documents that you're going to need to operationalize incident command at your facility. If you go to the website in Arizona or in Texas or in New Jersey or even the American Healthcare Association, all roads seem to lead to CAF and the California Association, where all of these documents can be found. You know, CMS came out with a report that was a follow-up to an earlier report following the tragedy of Hurricane Katrina, that basically said long-term care and other healthcare providers need to do better. We need to be better prepared for disasters, that we've got to understand that based on this focused OIG report, that even though 92% of nursing homes at the time were passing survey, we need to know that there were a lot of gaps and vulnerabilities out there that we need to overcome. CMS came out with some documents, some guidance documents, and other resources that ultimately kind of transitioned into the rules or the requirements of participation. And you got to understand that change is not only on the horizon, change is here when it comes to requirements of participation. For those of you that it affects, you're probably pretty familiar with this. The rule was rolled out in December of 2013. It basically made the case that the existing guidance in places like hospitals and nursing homes on emergency preparedness was just not comprehensive enough for the complexities of actual emergencies. And we knew that that proposed rule was going to impose extensive conditions or requirements of participations on providers like you. We knew that your plan had to be based on something, not just arbitrary or geocentric factors, that it needed to be based on a risk assessment, that it needed to be developed with an all hazards approach. And that's the key that I want you to understand. It's not just about a plan anymore. It's an emergency preparedness program that is multidimensional, that includes policies and procedures and the kinds of things that a surveyor is going to be looking for during the survey process. You can't just throw down a binder and say, here's our plan. The surveyor is going to want to look for P&P that's going to fortify the plan. They're going to want to make sure that your program and your plan in your policies and procedures are based not only on your facility, but on the community in general. You've got to make sure that you're reviewing that plan annually. And under the new ROP, you as a facility have to identify the specific amounts of subsistence or the stuff that you're going to need for your patients and your staff. And that includes critical medications. You've got to have a program that includes policies and procedures that assesses your facility population. You've got to look at those people that are at risk in your community. You've got to make sure that you can maintain those services during an emergency or a disaster. And it's all focused on continuity of operation. There are resources out there that can help you develop a continuity of operation plan so that you can clearly identify delegation of authority and succession planning. The new ROP states that you need to be cooperating, coordinating, and collaborating with not only local, but regional, tribal, state, and federal entities as well, because whether you know it or not, you're going to be part of that emergency management dynamic. You've got to be able to have plans and resources that will keep you integrated as part of that response, that you've got plans that help you with appropriate documentation, that you're participating in local healthcare coalitions. We can talk all day about that. That all the contact information that you have and you need is available to you in a moment's notice. CMS also says that you've got to have alternate sources of energy and alternate provisions in place to make sure that you are maintaining safe temperatures in your facility to ensure resident health and safety, but not only focused on your residents, focused on the storage of your provisions, your medications, your food, your water, so that you can continue your operations during an emergency or a disaster. Of course, you know, that emergency or alternate power source has to accommodate emergency lighting, exit lighting, fire protection systems. And here's one that the surveyors are really focused on, because you don't think about it until you're day 2 or day 5 or day 7 into a power failure, and all of a sudden your sewage and waste is backing up. You have to have a plan in your subsistence plan that identifies how are you going to deal with sewage and waste during an emergency. That is how deep these new requirements of participation drill down. And when you do your risk assessment, you might determine that you might need to expand your emergency generator capacity, or you might need to bring in some battery capability or come up with alternate provisions to get through the emergency. CMS is focused on your generator and the risk analysis that you need to do, the testing and so forth, the ability to have resupply and things of that nature. You got to keep track of your residents. You've got to keep track of your staff. You've got to make sure that you've got protocols in place to evacuate your team, to evacuate all stakeholders in an emergency. And you've got to be able to communicate with everybody. You know, it's a matter of should I stay or should I go? Do we shelter in place? Do we have policies and procedures for staff and volunteers that might spontaneously and organically show up? Do we have systems in place to maintain the safety, security, the confidentiality, and the availability of medical records? You've got to have plans for communications that include redundancies that are compliant with state, federal, and local laws that will help you stay connected to everybody that's part of that emergency management dynamic. You've got to make sure that you're training your people, that you're doing the drills, that you're doing the exercises, that you are focused on your emergency operation plan, and your training and exercise programs are focused on your policy and procedure. Under the new requirements of participation, you've got to participate, if you're a skilled nursing facility, in a community-wide drill on an annual basis. And in addition to that, you've got to do a facility-based drill or a tabletop exercise. There is a lot of requirement out there. And I don't see you on the call right now, but I know by my experience, a lot of you might be getting overwhelmed at this point. When we're talking about things like doing a tabletop exercise or a full-scale drill, you've got to understand that when it comes to compliance, it's not compliance for compliance sake. But when it comes to compliance, there are e-tags that are out there. The new e-tags are flying. Surveyors are looking to make sure that you're prepared. They're looking to make sure that your program, that your policies and procedures are in place, because enforcement has started. Your safety surveyors are going to be looking for evidence that you've got a program, that it's constantly evolving, that it's robust in its training drills and its exercises, that it's ready for immediate implementation. Because when it boils right down to it, it's all about culture. Have you established, am I motivating you to establish a culture of preparedness into your facility? Because when we get to the ultimate goal, what is that ultimate goal? Of having fire, police, and everyone working together. Well, it's interoperability. There are resources that are available online where you can go to the FEMA websites, and for free, you can sign up, go through some of these courses, take a test at the end, and get a great certificate that you're going to hang up in your office, so that when that mock surveyor like me, that life safety surveyor or a family member comes into your office and sees that FEMA certificate, they're going to get an impression that you're prepared. Lots of resources that are out there, tons of resources. Go to your state association, go to the CDC, go to the Ask for Tracy website, go to CMS, and look for everything that's out there, including commercially available templates that are out there. This is one that I actually worked on with a company that many of you are familiar with, MedPass, but that is an all hazards emergency management template and resource guide that will help you develop that plan. And don't forget about technology. States like Arizona and California, we've worked with a company where we got a disaster app that our providers can upload their plans, their policies, and procedures, because when that storm hits, when that adverse event occurs, you've got to be ready for anything. You've got to understand that when your roof is torn off, when there's smoke and water and damage to clean up, that you've got a plan for recovery and restoration, because it's really all about getting back into business. So what's some potential risk exposure you've got to worry about? Your stakeholders, your customers, they expect that you've got an emergency operation plan and program. They don't know this, but they want you to have a plan that's an all hazards plan that will deal with every emergency, that you use things like incident command, that it's updated regularly, it's reviewed, revisions are made as needed, because when we get to the bottom line and we look at some of our other potential risk exposures, we know that they've got an expectation of good planning, preparedness, response, recovery. They don't want you to have handshake agreements in place. Your stakeholders expect and demand that you've got business continuity plans in place, because when we do get to the bottom line, here's the way I'm going to sum it up. Long-term care providers like you cannot control what's going to come your way. But you've got to understand that it can happen to you. But you can control your levels of preparedness, response, and recovery. If you understand how people respond in an emergency, and if you train them and educate them and motivate them, you'll develop a culture of preparedness. If you know the hazards and perils, you've done good HVA. If you've got a system of command and control, regardless of what the hazard is or the emergency is, you've got an all hazards plan. If you're planning to recover, you're limiting your service disruption. If you know the regs and the trends, you know compliance. And the bottom line is good, robust disaster management will lead to a reduced risk exposure. So the time goes by so quick when I'm on a call like this, but I hope you enjoyed what we presented, and we're going to have some time for Q&A. But at this time, I want to turn the program over to our sponsor at Omnicare, and Nancy, take it away.
Well, thanks so much, and that was quite a robust overview of emergency preparedness for long-term care. But I will tell you that we often get questions here at the pharmacy about our own plan, and we're happy to share some of those details with our customers as any vendor would. And also, we would expect that our customers share their emergency preparedness plan with us. I will tell you that the only way to do this effectively is to manage your safety committee as you do any other QAPI committee, and assure that there is someone who leads it. But what happens in a real emergency are those people who sit around the table and do tabletop planning may not be in the facility during the emergency itself. And that is when you need to designate commanders who may or may not be nurses, may or may not be physicians, to take over the roles so carefully planned for your own emergency. However, as previously said, you will not be able to do a thorough job without following a template. I can only urge you to visit the Centers for Medicare and Medicaid Services, take a look at the templates and the guidance that's provided there, follow the checklist and implement the program, and then share your program not only with your vendors, but with the local police, state police authorities, and any other government agency, including OSHA or the EPA, and of course your local hospitals, so that you and they will both know what your capabilities are and what your needs are. Oftentimes we are challenged where other types of healthcare services are not, and that is that we have a tremendous number of residents who are either non-communicative, have lowered cognitive capabilities, and not really able to communicate at a very high level, especially during an emergency. And this is when we need to work with the different types of residents that we have within our buildings and develop plans around them. So take a look at your complexity of the residents that you have. Understand that you certainly will need their family or representative during times of evacuation and relocation, And while, yes, pharmacy plays an important role in ensuring that you send the medications in the current MAR with the resident upon relocation, the most important thing is the cooperation of those on your staff during the emergency, and train them with the ability to take over if you are not there during the time of crisis. So with that, I think we do have additional time for your questions, and we're happy to open the call to any one of those types of questions that you may have.
All right. Thank you so much, Stan and Nancy, once again for a very informative presentation. We've already had some questions come in from the audience. However, we'd like to remind you to use the Q&A area below the slides to submit your questions at any time. As a reminder, you can download the slides in the Resources tab to the right of the presentation window. All right, let's jump right in here. So, Stan, with the new CMS requirements, what are some of the challenges providers are experiencing today?
Well, one of the biggest challenges is the survey process itself. It's typically done with the life safety survey. And while some of us have been around a long time and are used to a typical life safety survey process, now all of a sudden the providers have been thrown a curveball, and they're dealing with the emergency preparedness elements as well. If you're a provider, you need to be prepared for several hours of focus on emergency preparedness. I can speak to the providers here in Arizona. Whereas our surveyor would come in, spend 3 or 4 hours, do a physical survey of the facility, look at documentation, and make sure that you're compliant with life safety, our providers are reporting an additional 4 to 6 hours, if not a second day, of focus on emergency preparedness following those E-tags that are out there. There's about 30-plus E-tags that are out there that apply to long-term care. If you go on the CMS website, there are checklists, there's itemization. You're specifically going to want to look for Appendix Z that will itemize all those requirements of participation by tag. And it's just something that they're not ready for. I wish I could have co-presented this program today with Nancy because her comments were so spot on. One of the requirements that I didn't drill down to is that the surveyor is going to expect that you are going to cooperate and collaborate with vendors like pharmacy. And they're going to want you to know, and they're going to need to verify that you've interfaced with them, that you know what their contingencies are, because they need to know what your contingencies are, and what happens if that pharmacy distribution point is affected by that disaster. You need to know that they've got backup. So, in a nutshell, it's just a complex survey process that providers that were first surveyed after November 15 of 2017, if you weren't ready for it, it was pretty tough. And we're seeing some facilities getting as many as 10-plus E-tags. I don't want to scare anybody because I've worked with facilities that I've helped prepare, either through the association or through my consulting practice, where we've gone deficiency-free because we know what those elements are, and we've got policies and procedures and programs in place that address them.
Okay, great. Someone in our audience is asking, do you need emergency planning for a tampered dose of a medication potentially exposing numerous residents to an infection control risk? I think you can probably both speak to this.
Well, I will automatically defer to our friends at Omnicare on this one.
So, thank you so much. I'm assuming that the question is with regards to a tainted medication. Well, first of all, follow infection control policies and assure that you limit and use single-dose vials, for example, whenever possible, and that even multi-dose vials are limited to a single resident. So your policies would be in place that if you have a, let's say, regular insulin, 10 mLs, and you need to take it for an emergency use, that 10 mLs will be used only for the resident for which the emergency was needed. So you cannot share these medications. In addition to that, when you have an infection control issue, your pharmacy should provide you with resident-specific medications as well as those that should be used for employees. During the times of infection, sharing is probably a bad idea, but based on the fact that I don't know exactly what the question is, of course you would have to report to the state that you may have an issue with cross-contamination or an adverse event, notify physicians, inform families, begin emergency care planning for those residents to assure that you know what you're monitoring, and call your pharmacist and your physician to work with them when you have a tainted drug product.
Wow, I never had my pulse quicken so much when I heard that question. And Nancy, am I glad you're on the call today?
Thanks.
Okay, someone else in our audience is asking, is there any federal funding available to subsidize additional emergency equipment for power restoration like generators?
You know, that's a great question. And a lot of the funding that's out there funnels into the coalitions. And I'll just speak to what I know of in California and in Arizona. The coalitions are the gatekeeper of the funds that are out there. And there are some states that have access to funding from the Hospital or Healthcare Preparedness Program or from CDC, where funding is available, where the funds are given to the coalitions. And in Arizona, for example, the Arizona Healthcare Association is a grant recipient of some of those funds. And we use those funds for educational programs. We do provide some resources like templates and incident command vests and things of that nature. But typically, you've got to go through the process of starting with a state association or going to the Department of Health or finding out from the coalition that you belong to or should belong to if funds are available. I know in some states like Utah, where I've worked, the answer is yes. They were distributing money a few years ago where providers were getting money for generators and equipment and things like that. But it differs from state to state. The federal government is really tightening their reins on that money, and some of that money has disappeared. But there is money available. You have to check in your specific state.
Okay, and it looks like that's going to be all the time we have for questions today. We do have some final instructions regarding CE credit. Please do not leave this page. Continue to stay on the platform, and you will be automatically redirected to a survey, which you must complete in order to get your certificate. For those watching in a group, as a reminder, please download the group submission guide in the Resources tab to the right of your slides and follow the instructions provided. Please note that CE credit is not available for the archived webinar. It is only available for the live event on May 3rd, 2018. I want to thank Stan Szpytek and Nancy Losden once again for an excellent presentation. I'd also like to thank our sponsor, Omnicare, for making today's program possible. Finally, thank you to our audience for participating today. We hope you'll join us in the future for another I Ask webinar. This concludes today's presentation.